For those that don't know me, I'm Sean Cox, Director of Prisons for the Hepatitis C Trust. It's a privilege to be here today and be asked to present our prisons and probation elimination plan. My plan now is just talk roughly through what we've achieved so far and where we need to be going. You're all going to do the hard work of coming up with the ideas about how we can get over the line and reach that micro-elimination and maintain that micro-elimination. And as Mark is late arriving, he's going to sing for us in a minute. So for those that aren't aware about the prison estate, I know you're probably aware of how many prisons you've got in your own ODNs and the reach, but across the board, we've got 114 adult prisons we're currently working in, all split down by the NHS commissioning regions, with some exceptions of the IRCs. The juvenile estate we're starting to engage in, and I'll talk a bit more about that following what Mark mentioned about the women's and babies, and also the secure training centres as well for the young population of the 14-year-olds as well. We're going to start looking at what we need to do in those environments. Prison information, what we've achieved so far, where are we at the moment? Do I want to talk about micro-elimination? Do I want to talk about the NCR dashboard data? Do I want to talk about individual providers data? We could, and we'll probably have discussions, and there'll be variable data. But I think what we need to recognise across the board, taking that to one side, when we started this programme, reception data across the board for BBVs, opt-out, being that we'd had the opt-out policy probably since 2014, was only around about 20% uptake rate across the board. So we knew we had a lot of work to do. Over the last 5-6 years, it's gone up drastically. We're now nationally at about 74%, so massive increase. So we're only 1% away behind what the national target is, hitting 75% within Department of Health. But for us as an elimination programme, we want to push that to 95%. Now, we have some pockets of really good practice there. Some people are hitting 98, 98.9, 99.9%. We also have some that are only hitting 10, 15, 20% reception data. And some of those conversations come up just now with the previous speakers about actually some of the guys and the women are saying no because they only got tested 2 weeks ago at a different prison or the drug services, etc. So we need to work out how we can manage that a bit better. Hits was mentioned earlier on. We do have 45 planned. We've done about 55 already during this programme. We're now going back and doing some re-hits so we can test the data, see where the strategy's working, are there any gaps in the strategy, all looking towards how we're going to eliminate it and maintain it going forward. We currently have around about 12, I've put 12 prisons on there, but it's normally about 12 to 14, it does vary from month to month, that currently have that micro-elimination certificate, and I think Mark alluded to that earlier on. Some people gain it and then some people do lose it, unfortunately, due to data, but we need to push that, we need to drive that, because I do believe there's prisons out there that have achieved it, but yet have not nominated themselves as being an elimination site. Hep C trusts are out there, along with other partners delivering training to make sure we're raising the awareness out there. We've even got peers now down at reception doing testing to support the healthcare teams as well, which is just amazing. And also the opt-out testing, we're still doing training there. We're still finding people not offering that question in the right way about opt-out and making it more like an opt-in still. And that may be because of the churn of the workforce, changing personnel, etc. But we need to keep that training, keep going. Probation, someone just mentioned probation. Overall, there's 290 thereabouts locations. We think most of them will open up now post-COVID. And again, they're all broken down into total regions. So it's a big pocket of people we need to go and engage with there. And probation, I think it's fair to say, we're one of the last organisations to really open their doors up post-COVID. So we're probably a little bit behind where we need to be with that one. The probation information we've got, there is a national data set of data we collect from NHS England's national perspective, same data sets we do for all the hits. We've not had too much of that data come back, so the data I'm going to present now is very slim pickings. We believe there's more data out there, we just haven't received it yet. But where we have gone and tested, and we've tested over 50% of the approved premises now, very few have come up positive because most of them were tested and treated in the prison system, but we have picked up a couple of new cases. In probation, we've done around about 800 tests. This was 2 years ago data, and we think we've done a lot more now. And again, we found a few PCR positives there that went on to treatment. Currently, we're having national meetings. So for those that aren't aware, each probation area has a health and wellbeing lead. They will attend a national meeting with their bosses. Georgia and I have been actually going to sit on that meeting as well. So we present what we believe they should be trying to do, what obstacles they're getting. Because something we learned from the approved premises was we as a trust would go and knock on their door and see if they want to support and have some testing done. Then the ODN nurse would go there. Then maybe the drug services might go there, part of their outreach. And the criticism we had back was, why are you lot not talking to each other? Fair point. We learned by that, and now we do it more collaboratively so we don't annoy probation like we did at the approved premises. Again, we sit on the national meetings. And I mentioned about the spreadsheet. I did ask Georgia to send it out in the next ODN meeting, ODN's monthly meeting bulletin, about saying the importance of getting that data back, and could we get Q1s and Q2's data back by the middle of October, because then we can analyse that data and see how far we've come. Other health and justice settings we need to be looking at. I think Mark mentioned a couple of these earlier. Immigration removal centres, massive increase in reception testing in some of those IRCs now, which is amazing. Forensic units, you're going to hear a little bit about later from one of my colleagues. Police custody suites is a big area of uncertainty, what we can or could we achieve within that setting, but we're currently working on a plan there. The mother-to-baby transmissions, so we're working with NHS England and the paediatric team to look at how we can ask those mothers that have been positive for Hep C, whether there's concerns around their children have been transmitted earlier on in their life, etc. Very sensitive conversations, going to be very difficult to manage, but hoping to roll out a programme over the next few months around that one. And I'll put in the armed forces there for two reasons. One, because those of us that work in health and justice, it's health and justice and armed forces, but also it's a big cohort of people that probably have not been tested yet, another big employer. So when we talk about earlier on about those ones that we need to perhaps reach that haven't engaged in risky behaviour as we know it is in IV drug use, etc., but may well have had a tattoo when they were serving abroad, etc. You may get a few of those come up, and it's those few that we need to go and find, those really hard ones to find. So just a bit of information. We are seeing an increase in reception testing, which is good news in the IRCs. We have our first HIT plan for an IRC in the next couple of months, which will be good. We have some data coming through from pilots in the forensic units. Again, you can hear about that later. Lots of conversations and planning meetings to see how we can work within the police custodies. Early conversations ongoing with the MOD, and business cases are currently, as I said, being written to go and work with the paediatric side. Could not do a whole presentation without mentioning the importance of the peers. With all this lot, the peers are there as a wraparound service. I think Mark alluded to that earlier. And a bit I couldn't put on the slide because I submitted them last week. We have just been nominated for an Inspire Justice Award. We are a finalist for the Prison Peer Programme, which is a massive piece of work. So let's give ourselves a round of applause for that. That's brilliant. So I look forward to going to that meeting in a couple of weeks' time. And now it's over to you. So you can't all just sit there staring at the screen all day, so I think you'll all get a bit bored. So as you've probably picked up, we've broken down into two groups. We will swap halfway round. So I will move into the other room and Stuart will come into this room and you'll focus on the community bit. But today, here now, we're going to focus on the criminal justice bit. It'd be great if you can work in tables of 6 to 10. That's hence why I asked you to move earlier. Identify someone that can do the scribing, little notes. You've got plenty of notepads and pens on your tables. Then ask someone that's happy to just feedback, maybe just for 1 minute of what you've written down. We have around about 30 minutes, slightly behind time. We will have a few minutes for feedback, and there will be a couple of minutes just for the presenters just to change over. For those that are online, you can join using the YouTube chat link, so please make your comments on there for us and we'll pick them up later. But basically, I just want you to all give some food for thought for, in the criminal justice setting, what has worked well. There's a lot of good stuff out there we really should be proud of and give ourselves a good pat on the back. But what barriers and issues, have we faced or have you faced during that period of time? What do we need to do differently to achieve and maintain microelimination? There was a couple of things that I mentioned earlier on about data sets. Dream world, could we just have one health record across the whole universe? Would be lovely, wouldn't it? Or even just in England. Those sort of things. They're the things we want to be able to go back and try and champion at national level. Should needle exchange provision be in prisons? We haven't got any HMPPS colleagues here. They will probably argue no, because we haven't found the evidence to say there is transmissions going on in the prisons. But yet, do we need to try and find that data? And what takeaway key messages can you as individuals take away back to your ODN from learning from other people around your table today? And please just remember, even though it's prison and probation focused, please, those that work in the community setting, you've got so much knowledge to transfer across to that environment. Likewise with prison to community when you get to that point after this session. So if I leave it to you guys to start writing, chatting, and thinking. Let's just check my clock. Now we're slightly 5 minutes behind, but give yourself 3 or 4 minutes per question, and then I'll give you a little nod after every 3 to 4 minutes has come up, and then we can move on to the next question. Or if you want to work differently in your groups and just go, I'm not sure we can use this phrase anymore, sort of blue sky thinking, and work in your own methodical way, that's equally fine, but just listen out for the time count. And I will give you a 2-minute warning when we are at the end of the time for you just to prepare your feedback. I think we're going to have 1 table, 2 tables. Can you 2 join? All that way? So 1, 2, 3, 4, 5, 6. I think these 2 tables can join together. They want to participate. The 2 lads here just sit on their own looking busy. Yeah, does that work for you guys? Everyone clear? Is it clear as mud? And those online, don't forget, please answer the questions via the YouTube chat. And I'll keep popping backwards and forwards and giving you a few timer reminders. Thank you very much. That's about 4 minutes elapsed so far. We've got about 8 minutes left in total. And if I give you just a further 2 minutes, and we've had some questions also from the YouTube chat, which I'll go through beforehand before I start going around the table. So 2 more minutes, please. Okay, thank you, everybody. That is your allotted time up, I'm afraid. If you still feel like you've got a few more things to write, happy for you to do that while I go around the room, but if you don't mind just doing it quietly so we don't interrupt the other speakers. Just going to read a couple of quotes from the YouTube channel that's just come through. And it's a very consistent approach. 1, 2, 3, I think it's 3 or 4 comments, all really saying the biggest barrier at the moment is to be able to maintain anything like good reception testing or routine testing about lack of staff. They just haven't got the resources at the moment, so therefore it gets deprioritised. We could all sit and argue whether that's right or wrong, but that is what they're coming back with. Change of providers also has an issue, a knock-on effect, because obviously their priority is to get the new staff trooped across, etc. So that has a knock-on effect as well. So certainly seems to be workforce is the issue coming from the comments online. So in no particular order, I've got a couple of colleagues going to go around with the microphone. So shall I start with the first table to my left, if that's okay? Did you pick up a nominated speaker just to give a couple of headlines from your conversation, please?
Hi, I'm Hayley, the HMP Birmingham nurse. Nice to meet you. So we discussed all of the questions. We haven't wrote many answers down, but we did say that what we felt had worked well in criminal justice settings is front door testing. That's a no-brainer. because once they come in, especially in a remand jail, you know they're going to shift about within a couple of weeks, especially that they don't get sentenced. They're getting sentenced quicker, at the moment, because COVID, after that, they've caught up. So they're not staying for long. So that initial test we've all discussed is brilliant. And testing, full stop, and the quickest test. Because in the old days, we used to have to wait 3 weeks for an antibody to come back. I think them days are gone now. So, and around the table, everyone seems to think that testing has worked well. And did you have any other points? And having a link, yeah, and communication, and all the team knowing what we're doing, why we're doing it, and also the peers. Hep C peers and the prison peers are absolutely amazing, how we've trained them up and how they do the work they do. I can't take all the credit for it. They actually do the oral swabs, and we're grateful for the funding and hope that continues at HMP Birmingham. But however, the barriers we found was testing kits, the availability of them, and around the table, the different ones that we use, and the best way forward with, obviously, cost is always involved. Having the right kit, having nurses and members that want to do the testing and are passionate about it, and the reason behind it, why we're doing this. So at Birmingham, initially, we're only testing for Hep C, of course. We'd like to test for HIV and Hep B on the door. They're going to get offered that within 7 days anyway. That doesn't sit nice with me, but I have to go with what's going on in the prison. So my job as a Hep C nurse is to concentrate on Hep C, but when they see me, they get all of the testing done, if they haven't already had it done. And communication systems, we use System 1, which is live in most prisons, so I can engage with that and link. I know a few people around the table from linking in with other nurses when they move about. So for us, it's holding the prisoner, making the first contact count, and offer them everything you can at that point, and getting a good relationship with them, so they understand if they don't treat it now, they are going to have problems as they get older. It will not go away on its own. Treatment is the way forward, and it's curative. Other things, takeaway messages, was we talked about testing and communicating with our colleagues and ensuring that patient is known, obviously securely, and emailing each other even just for questions. Some people say to me, what testing do you do? And I would say that to other people. What's your testing situation? We've turned our pathway around, but other people haven't, and there's challenges for a long time. And everyone seems keen on everything here that we've talked about. So joint working and communication is the key message.
Excellent, lovely. And I'm really pleased about Birmingham have got where they are now, because it's a long road, hasn't it, Hayley? It's been a long road, so well done, Team Birmingham, on that one. Just mindful of the time, we will probably run out of time if I'm not careful, so we can just keep it just a quick 1 or 2 comments coming back. If I go to the table, probably my furthest there with Colin Lawton on it. Put your hand up, Cole.
So I'm not going to repeat anything that was said before. So things that go well, although they did say like people being tested on the way into prison, I've noticed more often people getting tested on the way out as well, which works well. So barriers, we were talking about like that there's no consistency between different providers and different prisons. Sometimes people can't get to their appointment because of lack of staff to get there. You don't always know where people are going to be living when they're released, and it can be hard to find the right person to pass that information on. There's no consistency around how you provide your medication. So even within my ODN in the North East, they've got the ability to directly give someone medication. Ours has to be delivered. And then talks about the lack of space to deliver group interventions and education in terms of making people, preventing reinfection and making people realise they've been at risk. What we would like to be done differently is that ensure that when people leave the prison, that the medication goes with them. I was talking about that, like when people go to court, the meds don't always go with them on the van. So then they could be released from court. They'll be like 200 miles away from their medication. And it has been pointed out that if there is an incomplete treatment, it can be reported on the yellow card system. For doing differently, that perhaps people in different roles could be testing, so that it could be anyone can test. It's quite a simple thing to learn. So maybe there's an opportunity to involve people from other roles in testing. So just very much in terms of things that we haven't talked about in terms of our key messages, just regular clinics and people being able to get to clinics. No point testing someone if they can't get seen and the treatment gets started. The end.
And yeah, probably my bad timekeeping. But so what I'm going to do for the last few, so all these will be kept. So if you can keep hold of them, just put on top of your paper, prisons, and one of my colleagues will come around and collect them all, and we will write them up and send them out. But for the last minute, has anyone got anything they really want to share with the group that hasn't already been said yet? If so, stick your hand up and we will get the mic to you.
So the main thing that me and Lynn find in the prisons when we go around is staff attitudes. You know, you walk onto a wing, the guards just walk away from you. They don't want to engage with you. So I know me and Lynn are working quite close with the prisons, getting staff induction on day one and drilling it into the staff and building that relationship with them from day one. And I think that will be a way forward, definitely. The other thing that I find well is the CEFID machine at Preston. Builds of it, you know, you get an RNA within an hour, we can get the patient on treatment within a week. And I think that works really, really well. I think that's about it.
We've probably got about a minute left if anyone else wants to.
Don't need that.
Don't need that, do you, Nicola? But we do for the people online.
Yeah, so we have CEFID machines in our remand prisons, especially in Yorkshire and London, which has had a massive impact. So all our guys are tested on reception. When they come in, within 24 hours, they're on the CEFID machine, and the same day they have a PCR positive, they're referred into the ODN. I think the quickest, and I think Ashley's left the room, the quickest we've had is a guy started within 3 hours at our immigration removal centre in London, which was great work. But I agree with what the lady on the next table has just said. I found initially a lot of stigma with the staff, nurses, who, well, why are we testing them? It's not important. It's their own fault and things like that. I've had some difficult conversations with some nurses that no longer work for us. But yeah, I think stigma, ironing that out is one of the biggest things, especially in reception.
Excellent. We've time for one more. Anyone got the last at this table here? Hayden, lady in pink. The lady in pink.
Thanks, Sean. So on our table, we've got people from a Cat A prison, which presents very different challenges. So we had a little bit of a discussion about how you can try and engage hardcore non-engagers with BBV screening and how we could try and get education in, because it's a very different environment to, I think, what everybody else has been talking about.
Excellent. And it may well be worth us setting up, we've got the IRCs as like an ongoing working group. Maybe we want to do something with Cat A's going forward as well, having a bit of a working group for Cat A's as well, because they are a different cohort, absolutely. So, yeah, I'd like to thank you for your time. You'll have my colleague Stuart Smith coming next. He's slightly better looking than me and probably will do a far greater job. But please enjoy that session, and I will see you all in lunch very shortly. Take care.